Hello everyone, I'm Shanaz Jivraj. I'm a consultant in obstetrics and gynecology at the Jessup Wing in Sheffield. And I'll be speaking to you today on this online lecture on the management of the menopause. The objectives of the lecture today are to distinguish between the perimenopause and the menopause, as these terms are often used interchangeably, to discuss when to give HRT and to weigh up the risks versus the benefits of giving HRT, how to prescribe HRT, what the National Institute of Health and Care Excellence guides us about giving HRT through their publication of 2015, and finally, a little bit about premature ovarian insufficiency, which is the new terminology used to describe the premature menopause, and what the British Menopause Society recommends in terms of HRT for these women. Now, by definition, the menopause is described as the cessation of menstruation. This happens in nature when ovarian activity ceases to function. The average age of the menopause in the United Kingdom is 51 years. But this diagnosis can only be made in retrospect after a 12-month period of amenorrhea. Remember, an individual's periods will stop once they've had a hysterectomy, but that does not automatically mean that their ovarian activity has ceased to function, unless, of course, they have had what is described as a total abdominal hysterectomy with bilateral salpingo-oophorectomy, where the uterus is removed together with the ovaries. On the other hand, the perimenopause is the period leading up to the menopause. And this period is characterized by irregular periods and symptoms such as hot flushes, mood swings, urogenital atrophy. And remember, these two terms, menopause and perimenopause, are often used interchangeably. Specialists and experts in the menopause often divide the impact of the menopause into the short-term, medium-term, and long-term consequences. In the short term, vasomotor symptoms tend to be common. These may be experienced by up to 60 to 80% of women in some studies, lasting an average of 2 to 7 years. Vasomotor symptoms are symptoms such as hot flushes, night sweats, and these may have a profound impact on an individual's sleep, on an individual's mood, on an individual's quality of relationships, and hence can have a profound impact on an individual's quality of life. Other generalized symptoms experienced by women in the short term are mood changes and irritability, loss of memory and concentration, and symptoms such as headaches, dry and itchy skin, joint pains, together with the consequences of loss of confidence and lack of energy. In November 2015, the National Institute of Health and Care Excellence, NICE, published its guidance on menopause diagnosis and management, which clinicians now refer to when counseling women and managing women through the menopause. So NICE tells us that when managing a woman through the menopause, first and foremost, use a holistic approach. Give lifestyle advice. Use the opportunity of the consultation to assess an individual's lifestyle, smoking, alcohol, diet, exercise. Use that opportunity to try and modify their lifestyle to a more healthier lifestyle, reducing any modifiable risk factors. And often just modifying risk factors and trying to lead a healthy life, exercising, weight reduction, cessation of smoking, taking alcohol in limitation, Often just employing these simple measures will assist a woman overcome the symptoms that she's going through while transitioning through the menopause. Once that has been addressed, then inform the woman about the other options that are available to her, such as hormonal medication like HRT and vaginal estrogens to combat symptoms that they may be having, non-hormonal therapies that are available, such as clonidine, which is licensed in the UK to treat hot flushes, and the non-pharmaceutical alternatives such as psychotherapy and cognitive behavioral therapy. The main indication for prescribing HRT is the relief of menopausal symptoms. Giving HRT may have a beneficial medium and long-term effect, such as protecting against loss of bone mineral density and preventing potentially long-term consequences. It remains that the main indication for giving HRT is the relief of menopausal symptoms in the short term. That is the primary aim of giving HRT. There may be other benefits associated with it, but the primary aim remains that one, relief of menopausal symptoms such as hot flushes, mood swings, night sweats, and the other symptoms that we discussed earlier affecting an individual's quality of life. Once a decision has been made that HRT may be considered, then the risks should be discussed with the individual concerned. The risks such as breast cancer, the risk of thrombosis, and the risk of stroke. I have specifically indicated cardiovascular disease in parentheses because there is a hypothesis known as the window of opportunity hypothesis, which suggests that if HRT is started early in the menopause, so in the perimenopause or in the first 2 years of the menopause, then HRT may protect against cardiovascular disease rather than increase the risk of cardiovascular disease. So let's take breast cancer as a risk of HRT. NICE tells us that what we should be telling patients who are starting HRT is that the baseline risk of breast cancer varies from one woman to another. HRT with estrogen alone poses little or no change in that risk, and that HRT with estrogen and progesterone together increases that risk. This increased risk is then related to treatment duration and reduces after stopping HRT. This illustration also suggests that consuming 2 units or more of alcohol per day increases the risk by 5 cases. In women who are current smokers, there are an additional 3 cases. But women whose BMI is equal or greater than 30 perhaps pose the greatest risk in that there are an additional 24 cases of breast cancer in these women per 1,000 women aged 50 to 59 years over the next 5 years. Now, if someone's been diagnosed with breast cancer while on HRT, then it's imperative to discontinue HRT straight away. Do not offer HRT routinely to women with menopausal symptoms and a history of breast cancer. And HRT may be used only in very exceptional circumstances. In women with breast cancer who have severe menopausal symptoms, but not without active engagement and collaboration with the woman's breast cancer specialist. With regards to venous thromboembolism, so deep vein thrombosis and pulmonary embolism, the risk of HRT is increased by oral HRT but not transdermal HRT. In women who have a high risk of thrombosis, such as a strong family history or thrombophilia, it is advisable to have a joint decision about giving HRT made with a hematology who has a special interest in clotting disorders. So in regard to cardiovascular disease, NICE tells us that HRT does not increase cardiovascular risk when started in women under the age of 60 years. And the baseline risk of cardiovascular disease varies according to existing risk factors. So the presence of cardiovascular risk factors is not a contraindication to HRT as long as they are optimally managed. And we must remember the main advantage of giving continuous combined HRT is that it is a bleed-free type of HRT, whereas sequential HRT, by its very nature of giving a continuous background of estrogen with 2 weeks or so of progestogen every 4 weeks, will create an artificial cyclical change in the endometrium every 4 weeks, which triggers off a withdrawal bleed, and therefore an individual will get a period every 4 weeks with a sequential type of HRT. In someone who has had a hysterectomy or has a Mirena intrauterine system in situ, then additional oral or transdermal progestogen does not need to be given. The Mirena intrauterine system releases progestogen where it is required in the endometrial cavity and prevents endometrial hyperplasia. As things currently stand, the Mirena intrauterine system is licensed as a contraceptive and should be changed every 5 years. But when it is used to provide the progestogenic component of HRT, it should be changed every 4 years. Both societies advise that women who have undergone a premature menopause or have had premature ovarian insufficiency should be encouraged to have HRT at least until the average age of the menopause. The primary advantage being to prevent long-term consequences of an early menopause, namely early onset heart disease, osteoporosis, and early onset cognitive decline. Now, it is important to remember that HRT is not a contraceptive. If a woman is fertile and should be considered fertile until she is at least a year past the menopause, if the menopause happens after the age of 50 years, or at least 2 years past the menopause, if the menopause happens under the age of 50 years. In such instances, additional contraception should be prescribed. Non-hormonal methods to treat menopausal symptoms are available, but studies have shown that hormonal treatment with HRT is more effective than the non-hormonal methods to treat hot flushes and other vasomotor symptoms, including mood swings. However, if HRT is unsuitable or undesirable, then non-hormonal methods are available. A lot of these tend to be unlicensed, but clonidine is an alpha receptor blocker, which is an antihypertensive that is licensed in the UK to treat hot flushes. Other agents include SSRIs that are commonly used to treat depression, but when used to treat menopausal symptoms can be given in lower dosages. And antiepileptics such as gabapentin has also been used. And finally, remember that the need for HRT should be individualized to your patient. And do make sure that you rule out any contraindications before you start HRT. In particular, do not give HRT to anyone with undiagnosed abnormal vaginal bleeding. Also, please exercise caution in starting HRT in anyone over the age of 60 years. Thank you very much.